Welcome to Health Literacy Out Loud. I'm Helen Osborne, President of Health Literacy Consulting, founder of Health Literacy Month, and author of the book Health Literacy from A to Z. I also produce and host this Health Literacy Out Loud podcast series that focuses on many aspects of health communication, patient education, and health literacy. Today's guest is Karel van de Waarde, an information designer based in Belgium. Karel's projects often focus on medication information that is given to patients, doctors, and pharmacists. Karel teaches about information design to audiences worldwide. He's active in many professional associations, including the International Institute for Information Design, or IIID. He also was part of the team that developed the 2023 ISO International Standards for Plain Language. I met Karel when he emailed, asking me some really intriguing yet fundamental questions about health literacy. He wanted my opinion about whether health literacy is essentially about the ability of people or the ability of information. It was intriguing, those questions in our conversation. So much so, I invited Karel to be a guest on Health Literacy Out Loud. Welcome.
Wonderful. Thank you very much for having me. It's great to be here. Thank you again.
So your questions. Is health literacy about the ability of people or information? And yes, there are definitions that look at health literacy as an individual attribute or responsibility, and there are definitions that look at it the organizational side. But in our conversation, you and I talked about the fact that maybe it's not an either or choice. Maybe health literacy falls somewhere in between. Talk about that. What your thoughts are about that.
It has been bugging me because in the medical world seems to blame patients for having a low health literacy. And that causes all sorts of problems in extra costs, extra time for doctors, extra explanations they need to provide. And they don't provide a solution for low health literacy. They just say a lot of people have a low health literacy and therefore the costs increase. And I was wondering, if you state that, how do they measure health literacy? Because if you state one thing causes something else, the health literacy causes increasing costs in healthcare, then I want to see the figures.
Oh, Karel, let me take this from there. I've been doing this work a long time. Way back in those early days of health literacy, there were all these tests and word recognition tests and completing sentences and different ways that allegedly you could measure someone's health literacy. Those are not widely used anymore, and I'm glad of that. But is that what you're talking about, measuring someone's health literacy?
Initially, yes, because I design labels for medicine boxes and medicine packaging and instructions for medicines. And all the time I came across this health literacy theme. And my view is you cannot measure an individual's health literacy because the situation and the context and the way people interact with information depends on the situation.
Situation and the context.
Absolutely. If I've got a migraine and I've got to choose between the 5 or 6 painkillers I've got in my medicine cupboard, I'm not going to read the label. The type is too small.
Oh, of course.
The text is incomprehensible. I just take the one that I guess is the most useful.
All right.
But I hope the migraine disappears after taking a few tablets of a few capsules. But I cannot understand and I cannot read the text that is provided. So the context is essential. But 2 hours later or 5 hours later or a day later, when the headache disappears, my health literacy suddenly improves a hell of a lot.
I can relate to that a bit. A while ago, I was diagnosed with something that came out of nowhere, seemingly to me, and it was scary. And yes, I can read, I can do numbers. I know the healthcare world. This is what I do. But at that moment, it was overwhelming. It was like, who are all these people? What am I supposed to be doing? would have flunked any health literacy test at that moment. I got it later on. So is that what you're talking about, the ability of people?
Yes, but the test of health literacy at the moment seems to be, it relates between, I think, between 200 questions or so. And the fundamental question seems to be, do you understand the forms that are available for you? That's one of the fundamental questions. Do you understand the information that is provided by the hospital? And if the answer is no, I need help with that. I ask my parents or I ask my grandchildren to read it for me, then the patient is deemed to be health illiterate.
That's right. It's a yes/no question.
It's an extremely blunt tool, if it can be described as a tool, to determine if somebody is health literate or has got difficulties understanding. That is just not the right way of doing things, because the design of these forms and the design of the instructions and the design of these texts and the way information is provided on labels is so poorly designed that absolutely everybody has got problems with it. Even if you have a PhD in pharmacology, you still have to read the label and you still question if the contents is correct or not.
Karel, I'm thinking of something as you're describing this. A big recommendation always in health literacy is go ask the people filling out this form. Go ask the person, do some user testing. But as I'm thinking about what you're describing for user testing, it's often done under ideal situations. The person doesn't have a migraine. They weren't just diagnosed with something scary. They're not having to rush through a form. It's under ideal settings. Does that affect user testing? You're a designer of information. Tell me about the downsides of that.
The testing is absolutely essential. I think the testing is until now is frequently seen as a final step in after the writing. So you write and design first, and then you do the testing, and then you redesign. In my view, it's more like involvement of people in the whole process. Before you even start writing, you have to talk to people what they actually need to know or what they want to know, and that's not testing. That is interviewing beforehand and observing people how they use medicines or how they use materials before you start writing anything. And then during the writing and during the designing, you involve the same people again and say, look, what do you think of this? But even better is asking action-based questions in the sense of, okay, here you got the device, here are the instructions how to switch it on. Can you switch it on for me?
Okay.
Or there's an error message coming up on the screen. Here you got the instructions. Tell me what the error message means.
In real time.
In real time. And you can put people under pressure, a little bit of pressure. It's always depends on who you're talking to. But if the person opposite you plays the game, you can put a little bit of pressure and say, look, there's 4 error messages now and I need an answer in a minute. Can you find them?
Oh, okay.
And in a very practical test we did with the AIDs, the artificial electronic defibrillators for hearts, basically heart rebooters. The next generation of that is not a big device. It is on the back of your phone.
Oh, really?
And basically you snap it off your phone, you break it, and then you put it on the person.
Huh.
When you break it, the signal goes to the emergency unit with an exact locator where you are and that there is a defibrillator used at that moment.
Fascinating. I had no idea.
The problem was, of course, it is a medical device and it needs to be tested, or the instructions need to be tested. And you can't say, look, there's somebody dying in the next room, can you help me?
Right.
And there's very few countries that actually allow for these kinds of tests or usability testing, human factors testing in American. So we did the test in Abu Dhabi, and I asked firemen, nurses, policemen, military personnel, all people who are used to be trained in extreme circumstances.
Okay.
And based on that, we could actually test the instructions and the device, because you can tell a policeman, you've got 30 seconds. And they are trained to react within a policeman. 30 seconds is a long time already, but you can tell a fireman, it's urgent, do it as quickly as possible. And they realize that they will be put in that situation in real life in their training.
I'm thinking about a few different things. One, you as the designer, you as the user tester, had to be thinking about how can you get close to simulating a real life situation like this, but you had to go halfway around the world to find a group to do it.
Yep.
That's not the capacity for most people probably listening to this. You're special, you're a leader. I admire you for doing that. I want to make this kind of bring this down to the everyday level a bit. You talked about the issues of you have to consider the situation. You have to consider the context. And you and I had a side conversation about that role of distraction. Those are everyday problems that happen. How can everyday people work to solve that? And I'll tell you more about the listeners of Health Literacy Out Loud. They may be clinicians who are meeting in person with a patient or family. They might be someone writing health information. There may be someone in public health dealing with messages that the person may or may not have at that moment. And some designers like you, as well as people at community organizations. What can all of us be doing on our little sphere of influence to deal with these issues of distractions and context and situational understanding? That's a big question.
It's a big question, but it's absolutely fascinating. You mentioned different groups, and clinicians are trained to negotiate and have dialogues with patients, which is fantastic. They are usually in direct contact with people. Designers and writers are not. They're not in direct contact with the people they write for, usually. But the other way around, clinicians are not very good in writing and designing. They're not trained to do that.
True.
So it's teamwork in the sense that, yes, you need clinicians for the factual accuracy of the information and making sure that it fits into their way of working and thinking. And that differs from hospital to hospital or from clinic to clinic. And information needs to be designed and written in a way that suits the particular situation. And the only way to do that, in my view, is go to that particular situation, go to that hospital, go to these patients, go to these clinicians, and talk to them what they need to know and try to find out what they know already. The first discussions the dialogues are always, I record them, I ask them to record because they use words that I never would think to put in that context. They use a vocabulary that is not my vocabulary. It's not the clinician's vocabulary. It is the real people using real words.
You did that too. When I was coming up with your introduction, you were using terms as ISO standards. You're talking about this triple ID. That's not my world.
No.
My world, and I am savvy enough about health literacy, but it bridges between the two. I'm so glad that you're having that dialogue, but it sounds like a large part of that dialogue you're having, let's say with clinicians, is listening. It's not telling.
Yeah, and the word listening is absolutely fundamental. I teach a lot in Lucerne. We've got a workshop in early next semester, after the summer that is, on listening. We have a 2-week course on listening and asking questions. And I've never seen a university course. It should be obligatory for every first year coming in. Now we're going to train you how to listen.
How to listen.
And how to ask questions. And if the person you're interviewing or you're interacting with misunderstands the question or does not give an answer that helps you, how do you reformulate your question to make sure that you both understand each other?
That's fascinating. Oh, tell us a story. Make it clear for all of us how that role of listening and asking questions might make a difference.
A clinician might use words like pruritus.
Like what?
Pruritus, exactly. I use a word that is not very common.
Okay.
And it just means itching.
Itching. Okay.
It's medical, Latin, whatever word, but it puts you on the defense as a patient because you don't know what it means. And it's unclear. It makes the conversation uncomfortable. And by immediately asking, what do you mean by that? Can you explain that to me? I'm not familiar with that word. You immediately help You clarify the situation, take a lot of the stress away. That's what many documents and many instructions and many labels and many well-written texts do, is that they take the stress away. They've lowered the stress level because they are answering the questions that people have about a particular situation. But as soon as you open a tax form, or as soon as you open a pension letter, or as soon as you open a medical statement from your doctor, the stress levels go up because you expect it to be incomprehensible.
Oh, so you're expected to understand that great big word if you got this really bad itch or rash or something
Of
else
course,
like that. It's also hard to ask those questions. You can feel kind of dumb asking those questions. That is uncomfortable in there. So you listened, you heard this word, but you're the designer. How do you use that information as you were designing information sheets for patients in the public?
don't use it.
You don't use that word.
It doesn't get through the testing. If you ask people afterwards, it increases the stress again. So you just use the word real people use. So to finish that story about the involvement of people in the writing and designing, you start by interviewing and listening to people before you write. You involve them during the writing by trying to figure out if they understand what you're saying and if they can find what you're saying. And afterwards, you test or interview them again to figure out if you have succeeded and if you need to change anything. There's never a budget for testing because you're a professional writer. I'm a professional designer. We should know what we're designing, what we write. We don't need to test. I mean, we're professionals, 40 years experience, no problem. But if you say to a commissioner or a client, I need to interview 3 or 4 clinicians and I need to interview probably 6 or 7 patients about this topic because I'm not really familiar with whatever blood cancer circulation or blood cancers or whatever the disease is or whatever the situation is. Of course, there's a budget for that. You can take a few days for that. But after the interviews and the dialogues with these people, you say, look, I'm designing something that might help this situation. Can I come back afterwards to show you what I've done?
Mm-hmm.
And I've never met anybody who's not curious enough to say, no, I don't want to see you ever again.
Right, because they've invested all that time. They care at some level.
Exactly. And that means that, of course, I'm curious. And then usually that's an online dialogue, but you can actually send materials over and discuss them afterwards. And that's user testing.
Wow.
And you can get feedback immediately from in the beginning, and people can see that their work or that their words have an effect on the final result.
I used to do that on a much, much smaller scale. I worked as an occupational therapy on an inpatient psychiatric unit, but I was starting to get involved with health literacy. I'd write some teaching sheets. Sometimes in our morning meeting, we talked about whatever we needed to talk about that day. If there's a little extra time, I might say to the whole group, I was just writing about this or that topic. Can I share it with you? I'd like to get some feedback about whether you think others might understand. I learned so much by that. Karel, I want to take this kind of more full circle. You were talking about measuring health literacy and the costs associated with that. We've talked about kind of some of the variables. It's not either the health literacy of the person or the information. It's really built on that dialogue. Bringing that more full circle, how do you measure understanding?
By simply asking people.
Oh, okay.
So it is actually 4 factors that are essential. It's the relevance. So if people indicate that's not for me, or you ask me, you always work together. So you got a document or a website or whatever you're interested in, and you ask people to have a look at it, and you start asking questions if they can actually use it.
Okay.
And can act upon it. That's the absolute level. Is it usable? What would you do if something happens? Can you find it for me? And if it's clear what you have to do, then it's a successful document. It's the performance of that on that level. Then under that, we expect then, if people can use it, that they are understanding it.
Okay.
But that's in some situations that's not necessary. The famous example is a photocopy machine. You put your document on the photocopy, you close the lid, you press the button, and it's not two-sided. So you press it again. You don't know how the photocopier works. The model of that people have of a photocopier is just you trial and error. And if it doesn't work, you try something else. You don't understand it, but you can use it.
Oh, I really like how you are prioritizing the utility, the usefulness of information. What you shared today, Karel, I hope that listeners will put some of that into action too. You gave lots and lots of tips and suggestions and shared some stories and example. That's what this podcast is all about too, making it just a little bit better to communicate today than we did yesterday. Are there any resources you want to steer people to right now before we kind of close down this recorded conversation?
We've published the ISO standard,
ISO standard,
the
okay.
plain language 24495. It's expensive and it is a very basic thing. And most professional writers and most professional designers go way beyond the level that's in that ISO standard.
Okay.
So I would probably not follow that. It's more for organizations. But if you want to know more about the relation between design and context and how people react with information or act with information, then the IIID, the International Institute for Information Design, has got some resources and some conferences and some newsletters and so on that might be interesting.
Thank you. We will have that on your Health Literacy Out Loud webpage. Listeners, go look at the webpage. You'll get a link.
Brilliant.
Karel, I want to thank you so much for emailing me seemingly out of the blue a few weeks ago.
True.
To raising these important, really thought-provoking questions and for being a guest on Health Literacy Out Loud. Thank you.
Absolute pleasure. Thank you very much.
As we just heard from Karel van der Woord, it's important to have a dialogue as we create health information and materials. It's not just about the recipient of the information. It's not just about the designer. It's not just about the organization. It's about having a dialogue together about what is important to do and to know. But doing this is not always easy. For help clearly communicating your health message, please take a look at my book, Health Literacy from A to Z. Feel free to also explore my website, healthliteracy.com, or contact me directly at helen@healthliteracy.com. New Health Literacy Out Loud interviews come out the first of every month. Get them all for free by subscribing at healthliteracyoutloud.com or wherever you get your podcasts. Please help spread the word about Health Literacy Out Loud. Together, let's tell the whole world why health literacy matters. Until next time, I'm Helen Osborne.